So it's always about, for me, the title of the talk. So I'm very proud of my clinical limbo. How low can you go? How low can we go? Well, Dina showed us how low you can go in one care facility. We're not at 4%. FYI, we don't win, I guess. But for us, it really is balancing. It's a balance. How far under can you get under that bar? And where are we setting the bar? And all those kind of things. So hopefully, when you hear the story of our journey, Chris asked me to talk about our journey to trying to optimize antipsychotics. And this is a journey for the last 9 years. This has been going on for a long time. Oops, and I need to learn how to use this. Objectives, because I don't know, went to school too long, so I have to have objectives. But we've been working on medication optimization since way before all the sort of black box warnings about atypical antipsychotics. In fact, I was recalling in 1997, I worked at another long-term care facility, and the pharmacist, myself, and the medical director did a medication optimization project. We didn't call it that then. It was like, well, the average number is 9. Maybe we should get to 7. Like, we were just trying to do what we could to get these folks on a better medication profile. Okay, so I think it depends how low you can go. It depends where you work. I work at this great place, the Lodge at Broadmead. Where you work depends how low you can go. And I'm going to talk about why I think that. It depends who you look after. If you do look after 50% of the people who have psychiatric illness with schizophrenia, you're going to have a higher number. You guys all know this. This is not rocket science. But this is who we look after. And I apologize, the lamb is kind of over there. But we look after old, 40% are over 90, very frail, primarily men, because we have a lot of WW2 vets, who have dementia. 80% of them have a diagnosis of dementia, most of them in their last year of life. That's who I'm talking about when you see this data. And hear our story. Who you work with, how far underneath that bar you're going to get. This is our team. Sorry, David, that you're at the bottom. I didn't mean to put you down at the bottom, but you're at the bottom.
You know what? They just gave me a Joseph Circle for speaking up.
Excellent.
I'm feeling really sleepy.
So, you know, it's a huge team. So I'm glad Dina could do it with one person. I could never have done this with one person. We have 300 staff at the Lodge at Broadmead. Big place. And so it takes everybody to work together. It's a key. Especially to have dignified care. Beyond atypical antipsychotics, dignified care takes a team. I decided I would say what we think about dignity. This is what we believe. You guys have heard all these already. This is how I define how we can be dignified. We use something called the path of least resistance. Sandy talked a little bit about a similar thing. Dina did. You know, if you go in to care for someone and they say, get the heck out, then you get the heck out. It's a term coined by Supportive Pathways Care West in Calgary. We use their education, but the path of least resistance. I got to say something about language. My residents, we don't own any of these residents. Our residents, we don't own any of these residents. Paternalism is so prevalent in healthcare that if we don't buck against paternalism, we're going to have a really hard time providing dignified care. And also managing behaviors. I provide care. I assess behaviors, I try to understand behaviors, I look at unmet needs, but I am not there to manage someone, okay? I'm there to actually support their needs. Okay, now I forgot my thing. So then you have to come from a foundation, I think, of good best practice dementia care if you want to reduce atypical antipsychotics. And these are some of our foundation over the last 9 years. All our staff get 2 days of dementia care education, whether you are in administration, whether you are the receptionist, whether you work in laundry, everybody gets the education. We do have a clinical program. We have all kinds of documents up the kazoo. I don't know if anyone reads the documents, but our behavior care guidelines use behavior mapping, ABCs, similar to the PIECES program. We have all of that in place to support making sure we're using atypicals the best we can. I would encourage anyone who doesn't know about Pat Armstrong's international research work out of York University. She's doing an international study on reimagining residential care. So I would get people to go to that website if you haven't been there. She's doing some real work around exactly what we're talking about here today, unless somebody here is part of that team. Is anybody here part of that team? Oh, there you go. Someone here is part of that team, so they could talk to her. And we're currently looking at the idea of a dementia-friendly environment using an amazing set of information from the Australian government. If you haven't been to that website on dementia-friendly environments and their A to Z cheat sheets about how you can assess whether you're dementia friendly, go there. It'll make you provide better quality care, I'll guarantee it. We've done medication optimization for years, thanks to the leadership of Dr. Duncan Robertson, the medical coordinators, and everybody else at the team at the Lodge at Broadmead. Started way back a few years ago with the beers list. Duncan did a great presentation called Beer and Beyond, and it was all about beer. It was much fun. And then along came all the concerns about antipsychotics. So I was told that I should talk about our little initiative that we did. So here's the numbers for people that want the numbers. In June 2011, we decided we were going to find out who and how many people at the Lodge at Broadmead were on antipsychotics. So you can read the numbers. Just so you know, we also did things like looked at the dosage, and the dosages were all under what you would, you would want, et cetera, et cetera. And most of the medications by lodges, certainly there were more people that had, the higher percentage were on lodges where there were people with later stage dementia who are still ambulatory, many men, et cetera. But I think this was an important result. So we audited all the charts, and I was very happy to see a couple of these things. One, there was actually an indication for use for most of them. 83%. I thought that was not bad, that I could find a documented rationale. And the most common reason was aggression or risk to self or others. There certainly was non-farm strategies on almost 60% of the care plans. Wasn't great, but at least we knew. Like, you don't know unless you look, right? And 40% we'd actually already been trialing people off these meds, so I was pretty proud about that. Of those 40%, in case people are wondering, 60% had to be put back on. Maybe not at the same higher dose, but they did have to be put back on, so just for those of you that are interested. But this was an interesting piece to look at the context for why things were prescribed rather than just the numbers. So we went along, trekking along, and guess what? People moved into the Lodge at Broadmead. 80 to 100 people die at the Lodge at Broadmead every year. And so people move in, and about 40% of the people that move in come in on an atypical antipsychotic, just like Dina mentioned. 8 people during that time were prescribed a new antipsychotic, about 1 a month. I don't know what it is everywhere else, but that's what we found. So, it keeps, the numbers go up and down, I guess is what I'm saying. These are the stats again. So we were able to discontinue a number of folks off of their atypicals, reduced a lot of dosage, increased some, and imagine people did die still on antipsychotics. Sorry to say. I think that's something we need to look at as an organization and kind of improve on, but they did. They have something like 5 to 7 comorbid conditions on, typically. So we did reduce atypical antipsychotic use over the time, even with the new people moving in and everything else. We were pretty happy about that. Again, well, I'm going to talk about could we go lower. That's the next slide. But that's our use. And you'll see that, a big percentage of these, and I was talking with someone at our table around, what does the number even mean, right? There's a large percentage there that had a PRN prescription, but never used the medication. So are they really on it then? I mean, it's on their MAR, right? So then you count it. But so there's some thinking we have to do around how we even report what numbers we report. So those were easy folks to actually get them discontinued. So these are some of the impacts of just doing the QI initiative. So I would recommend everybody in this room who hasn't done a QI initiative, take a look at what your actual prescribing are and see what you can do about it. Because just doing that, these were the impacts. The additional impacts were we reviewed our behavior care guidelines, made sure we had a section on atypicals and that kind of stuff in it. We looked at, we have a resource for the nurses at the Lodge at Broadmead that includes, we updated the beers list because there's a new beers list. We put in the Stopstart Articles, and just have a resource for the lodge nurses that are primarily licensed practical nurses so that they have an understanding about medication optimization and can use that information when they're talking to family members and physicians and other members of the team. So, of course we can get lower. And I just think I think we should all be looking at getting as low as we can. We have an auto stop that's starting, an auto stop starting. We should have auto stops. Auto stops should be for not just antipsychotics, right? If PRNs aren't used, why are they prescribed? We continue to always look at the assessment and apply our behavior care guidelines, do the same things that Sandy was talking about, really look at the person, make sure we know the person, just continuing to do that, even in the world where we have a lot of turnover where I work, a lot of people dying and people moving in. Turnover is not the most person-centered word either, but anyway, we have lots of people dying and moving in. How about that? And again, the non-farm things, I don't know, can we get lower because we start using other things instead? I mean, I don't know. We have very low benzo use. Does that go up now? I don't know. Does our SSRI stuff go up now, right? Do we start using more I don't know. We haven't, but I just throw that out there because you can give a really good number to somebody who's benchmarking a number, but if that's the only number they're looking at, it's just a question I ask the group. And again, we're in the process of, we developed a policy similar to what Dina was talking about. I haven't seen hers, but we have a guideline for the use of antipsychotics at the Lodge of Broadmead. And we've done lots of work to put it together. We kind of stalled it a little bit because of the provincial working group. But Fiona and I were talking, and we're actually going to trial that guideline on one of the lodges where there's a lot more. David, FYI, we're about to trial it on one of the lodges, and I think that will really help us to know if the guideline is going to be workable. So that's my other recommendation. If you're going to put out a guideline, and you're a big place like we are, it's good to trial it somewhere and get the kinks out because you need it to be adopted. And so when you have 225 folks and a whole lot of staff, you want something that's going to work. So that's where we're going to next. Again, I asked the question, these are just questions because I was told to bring questions to stimulate discussion. So, you know, how low is low enough? So if we did a 50% decrease based on, and I think right now, I think the latest stats I looked at, we look at them every month. Even if you start doing that, that'll be an aha moment for, I think, all of you. It's 21% or something. So we'd be about 12 to 15%, 33 folks. Because I like to translate it into people, right? Not just a percentage of numbers. So I think, okay, those 33 folks, so are those the right folks, though? Or should it be another 10 folks and maybe not? I don't know, right? I think you have to go back and look at the people that are on the medications. And I know everyone knows we're not, we're treating people, not benchmarking, but I don't know, lots of people talk about numbers to me that aren't in healthcare, and I think we put ourselves in a position where we could get kind of squeezed if we're too numbery. And this is my final thought to stimulate discussion. And I know you guys all know that, would all answer the same way as me, but psychiatric distress, I don't think it's okay for people to be in psychiatric distress because they are a 94-year-old veteran who is remembering World War II. It has PTSD that was never diagnosed, and oh, I know maybe it should have been an SSRI for the PTSD or whatever, but I don't believe they should, that last 12 months of their life, it's not dignified to leave them in psychiatric distress because we're worried about the side effect of these medications, and I leave you with that.